Hi, thank you so much for having me here today. My name is Kate Lally. I am a palliative care physician at Dana-Farber and the clinical director of our ambulatory palliative care program. And I want to talk with you a little bit today about communication to patients and families as they approach end of life. I want to talk about that in general, and then also to focus a little bit on COVID and the pandemic and the changes that we're seeing that perhaps are lasting after the coronavirus pandemic. So just some disclosures. I have nothing to disclose around this, and I want to thank my colleague, Rochelle Bernacki, who shared several of her slides with me for this presentation. So what I'm hoping that we'll talk about over the next half hour or so is to think a little bit about what the communication needs are of patients and families and how they like to hear from us about their medical conditions and what's going on. I then want to think about enduring changes to serious illness communication because there have been needs that patients and families have always had around communication, but some things have changed, particularly as we've moved more to telemedicine. And I want to think a little bit about how that's affected serious illness communication. I want to share with you some frameworks around communication and give you some citations and tools so that if you're interested in learning more, you can have access to those in the future. And then I will share those resources that you can look at. So I want to start by saying that there is a gap. There's a gap between what we say we want around end-of-life communication and what we actually do. So if you ask Americans, more than 9 in 10 say it's important to talk to their loved ones about their own wishes for end-of-life care. We generally agree this is an important thing to do, and we want to open that communication with our friends and families. But when it comes to actually doing it, when it comes to actually having those conversations, only about 27% of us have actually talked with our loved ones about what we want. And in one state, when you think about people actually talking with their healthcare providers, right? One could argue, yes, it's important to talk with your family, but really you should talk with your healthcare providers about your own medical condition and how that impacts the type of care you might get. And so if you look in one state, only 13% of people had actually had a conversation with their healthcare provider about their end of life wishes. And then if you look at the population who really should be having that conversation, those with a serious health condition, only 27% of those people had talked with their healthcare provider about their end of life care wishes. So again, we all generally agree this is an important thing to do, but when it comes to actually doing it, we're dropping the ball and we're not talking about what matters most to us, to our loved ones, or to our healthcare providers. And I want to argue that having these conversations with your doctor really can benefit patients and their families. Now, in my field, in the field of palliative care, there is some debate right now. Does advanced care planning make sense? Should we be talking with patients about sort of wishes around particular medical interventions? But I think all of us agree that talking about our illness, talking about our hopes, our fears, and having serious illness communication is important. And having these conversations early and often can really help patients have better outcomes. So we see more goal concordant care, which is really becoming, I think, the gold standard for what we should aspire to. It's not a goal that, many of us say that we want to die at home, and that's important if that's what we want. But I don't think we should be aiming to have everyone die at home, right? Some people do want to be in a hospital. They want the ICU. And so if that's what they want, that's the kind of care that they should get. And by talking with people and understanding their wishes, we are more likely to provide goal concordant care. It also allows us time to make informed decisions and fulfill personal goals. If it's so important to someone to be able to travel to see a child or a sibling who lives out of state, knowing that time may be short can allow them to make those kinds of decisions. And it can help with improving quality of life. While it may be hard to hear that time may be short or a disease may be progressing in a way that we don't want it to, it can really help us to have a better quality of life and a better patient satisfaction if they understand that and can make decisions for themselves and their families based on that. It also is associated with more and earlier hospice care. And again, goal concordant care is really our goal. But for many of us, we want comfort at end of life. We want to be at home with our family around us. And by having these conversations, it allows that to happen earlier in the disease trajectory. Having these conversations has been shown to keep people out of the hospital. So again, people who aren't choosing that aggressive care, if they know that their disease is more advanced, they may choose to stay at home to get that earlier hospice care and stay out of the hospital. And it helps patients and families cope. It helps open up conversations about what people are seeing, choices that are being made, and what matters most. And that can really help ease that burden of decision making for families. I often talk with patients when I'm talking about advanced care planning, or I'm talking about, signing a DNR order. I'll say, your son, if that's their decision maker, when you pass, your son will be so sad to lose his mother, right? That will be incredibly, incredibly hard for him, and he'll grieve that loss. But at least he won't have to feel guilty. Did I put her through things she didn't want? Did I put her through the type of care that she didn't want? And by making those decisions now, you can help ease that burden of decision making. And by doing all of this, we can really improve bereavement outcomes for the family after the patient passes. Now, I've just spent some time telling you about all these benefits, and I hope most of you listening agree that there are a lot of benefits to having these conversations. However, yet again, in practice, these conversations are infrequent, they are late, and they're limited. So when you look at patients with end-stage diagnoses, fewer than a third of them had an end-of-life discussion with their clinicians. And unfortunately, even if those conversations happen, they're happening late in the disease trajectory. So for patients with advanced cancer, often their first end-of-life discussion is 33 days before death, even though there may have been, for many patients, somewhat of a predictable decline over time. And 55% of those initial end-of-life discussions happen in the hospital, maybe with the team who knows them and has been following them for a while, but maybe not, maybe with strangers, and that can be really hard. And these conversations tend to be limited. They often fail to address the key elements of quality discussions. And that's what I want to spend sort of the next section of the talk about, is what makes a high quality conversation and how do we communicate effectively with patients around end of life. And I want to acknowledge before I do that, that having these conversations can be really challenging. It's easy for me to sit here and say we should all be doing this. And again, I think most of you would agree with me. Yes, we should be having these conversations, but it's hard. And it's hard for a lot of reasons. So for many of us, we never had training around this. I know I didn't as a resident, and sort of in my younger days, this is work I came to on the job. So for many of us, we've never really been taught the skill of effective communication. We also have time constraints, right? We have to pack more and more into a busy day, and that can make it really difficult to have these conversations. There can also be a lot of different attitudes. Should we be doing this? Does it take away patient hope? When should we have these conversations? And I've often heard doctors talk about harm. I had a doctor share with me about a conversation that he had with a patient about prognosis that didn't go well. And he said, I think I hurt her. Right? I think by sharing this information, I didn't have the right skills. I didn't do it well. And I worry that I hurt her by, not doing it effectively. So I think we worry about that, reasonably so. There's also challenges, particularly in the world of cancer, my world, as treatments have been changing, it can be harder and harder to prognosticate. That's true in a lot of diseases, dementia, heart failure, lung disease. Can we be sure about what the trajectory has ahead for someone? And that can often feel like a barrier in having these conversations. There can be ambiguity, right? Many patients with serious illness have a lot of different doctors. They might have a primary care doctor, a surgeon, a palliative care doctor, a heart doctor, a lung doctor. So who should take the lead in having these conversations? The primary care doctor might say, heart failure is a big issue. I think the cardiologist should be doing it. And the cardiologist might say that his primary care doctor has known him for 20 years. He should be doing that. And they both might say, you know what, it's better for the hospitalist when he's in the hospital. So who should take the lead with this? And that can be a difficult thing to figure out. And then it can be really hard to figure out who you should be having these conversations with. Who are your patients who are at high risk? If you think about your patient population, who has the highest chance of dying within the next year? Who has the highest chance of having a significant clinical decline? And it can be very, very hard to identify those patients to say, this is someone I really should be talking to. And I want to really get at the fact that these conversations on both the part of the provider as well as the patient can bring up a lot of emotion and cognition, as well as skill around the language that we use. You know, doctors often talk about hope. I mentioned that before, and I'll mention it again. But I've had doctors say to me, you know, I knew I could look at her and I knew she wasn't doing well. I knew time was short. I knew that this marked a big change in her clinical condition. But I didn't want to tell her because I didn't want to take away her hope. And I think when you think about that, it brings up a larger question about what patients hope for. If a patient doesn't have a long time to live, what might they hope for? And I think that's a key piece as we think about having these conversations. I also hear about trust. I just met this patient. You know, does this patient trust me to have what could be a very intensely emotional conversation? And then what words and language do we use as we talk with patients about what matters most? Now, all of what I just shared with you existed before the coronavirus, right? This has all been sort of long-standing issues that we need to address to effectively communicate with our patients. But COVID has now made this much more complex in ways that I think will persist even as we hopefully are coming out of the coronavirus pandemic phase. I think there's been a lot more increased patient awareness around end of life. I think we just hit the 1 million death mark in the United States. And for many of our patients, they've seen loved ones die suddenly, die unexpectedly from coronavirus, from an illness complicated by COVID. And so there's a lot more awareness about the importance of thinking about these types of issues. And patients often want to talk about their goals because things have become very much more to the forefront. I have patients say to me more often now, I don't want to go to the hospital. You know, we've had a history over these last 2 years of these no visitor policies, and who knows, that may come back. And patients are terrified of that. I don't want to be in this big hospital without my loved ones, without the people that I depend on there at my side. They worry that things could change while they're in their clinical condition, while they're away from the people they love. And there's been talk, much less so now than at the beginning of the pandemic, but around rationing of resources. And what would they be able to get aggressive care if they wanted it? In addition to all of that, which is a lot and very complicated, there's been an expanded use of telehealth. And I will say before the pandemic, I frequently would hear people say, you can't have these conversations on the phone. You know, none of us were doing Zoom or anything back then, but people would say, this is the type of thing, you've got to bring someone in and talk to them face to face. And I do think that's ideal. It's always ideal, I think, in medical encounters, if you can sit in a room across from someone and talk with them. But I think we've reached a point where we often have to have conversations with patients via telehealth. And I think it's become clear, and I'll share some data at the end of this presentation, that we can effectively communicate with patients via telehealth. And I won't go into this in any great depth, but there really are people paying attention to the concept of webside manner and thinking about your body language and how you operate with a patient via telemedicine. So I want to share with you a patient of mine, Mr. F, and think through a little bit about a framework of serious illness communication, and then think about how that could apply to Mr. F. So Mr. F is a patient of mine. He was 52, and he has metastatic lung cancer. Now, he's had it for a number of years and has been on sort of treatment after treatment, which have generally kept it at bay. But now he has really much more diffuse disease. And he's got increasing edema and dyspnea. And, you know, it looks like maybe he's got a pleural effusion. The treatment options are becoming more limited. He's gone through a number of clinical trials. He's gone through standard treatment. And there might be, you know, a trial in the distance, but it's unclear if he's someone who would be able to do that trial. And honestly, with his significant dyspnea, his significant pain, he could benefit from admission to the hospital, but he's worried about that. He's worried that his wife, who has been at his side this whole time, won't be able to come in and be with him. He's worried that if he goes into the hospital, he won't come out. And so we really needed to sit down and talk about where things are with his illness and think about what makes the most sense for him as an individual. Should he be admitted to the hospital for symptom management? Should we focus more on comfort and stay at home? Now, when we think about a patient like Mr. F, when I think about having a conversation with him, I'm someone who's done a lot of these conversations over the years, and I've had some on-the-job training. But for many of us, and again, me, when I first started doing this, we weren't trained. This wasn't part of our residency, wasn't part of our fellowship. And so we often feel like, I don't know what words to use. I don't know the best approaches in talking with patients about frightening and overwhelming topics. So this slide is from the Conversation Stoppers study. This was put out by the Cambia Health Foundation back in 2016, and they polled physicians to ask them about their thoughts and concerns in having serious illness conversations. And what they found is that almost half said that they frequently or sometimes are unsure of what to say during conversations around end-of-life care. And not surprisingly, if they've had some training in this, they are more likely to say that they feel comfortable. So I think really being open to having training around how to have these conversations can be a really helpful thing in allowing you to feel more comfortable and be able to talk with your patients more easily. So along those lines of training, I want to share with you a framework for goals of care conversations, what we call the REMAP framework. And I have at the bottom here a citation if you're interested in learning more. This has been adapted and used by VitalTalk, which is a well-known group that do training in serious illness communication. And I'll give you some links at the end if you're interested in learning more, because of course, I don't expect you to feel comfortable in having serious illness conversations in the next 20 minutes. But I want to give you a sense that there is a format that we use to have these conversations, and there are concrete skills that go into having this type of communication. So the REMAP framework, I want to kind of go through it here quickly, and then I want to go into each step in depth. So when talking with someone like Mr. F about his illness and where we go from here, it's often good to start with a reframe. I think we are in a different place now. Doing something like that, having a sort of a reframing around where things are, or sharing information about where things are with his cancer, for example, it's very likely to bring up emotion. So we should expect emotion and have some tools to respond to it. I think for many of us, that's what we're worried about. What if they get upset? What if they get tearful? How do I manage that? And we should expect that and use some tools to address it. So simple things like, I can only imagine how difficult this can be. We then want to map their values, because a patient could say to me, so what do I do? What comes next? And really, when you think about someone like Mr. F, who's deciding between more aggressive care in a hospital, going towards hospice, we need to really think about what's important to him. What are his goals? What kind of care does he want? And really explore those hopes and worries so that we can come up together with a plan to move forward. You then want to align. So, Mr. F, what I'm hearing you say is most important is, and then finally propose a plan. Given what you've told me, I'd recommend. So to go through those steps, each kind of one by one, it's always important to start with asking the patient what they know. Now, me as a palliative care physician, it's relatively easy. I can say, I saw you met with Dr. So-and-so, your oncologist. Tell me what he said. Tell me where things stand with the cancer right now. And with Mr. F, if he said to me, I met, again, I'm looking at him thinking he has very advanced disease, that there may not be a lot of treatment options left. But if he says to me, what, I talked to the doc, he said there's going to be another treatment, we're going to knock this thing out and I'm going to be fine. That gives me a lot of information about how I should shape my conversation, what he's able to hear, what he's heard so far. If he says to me, I met with Dr. So-and-so and I'm worried, I think he's worried too. I know we've gone through a lot of these treatments and he's looking for the next trial, but I'm worried about what comes next. Now I have a very different sense of where he is and what his understanding is of his illness. Now you may need to provide new information. You may need to say something like, the CT scan shows the cancer is growing. I'm worried our current treatment plan isn't working as well as it is before. And then acknowledge the change and ask for permission to talk more. You know, Mr. F, I think we are in a different place now with this cancer. I wonder if we can talk a bit about where we go from here. While I know that we've always talked in the past about the next treatment and hoping it will shrink the cancer, I hear you that you're worried there may not be a next treatment and what that means. And if so, I want to think a little bit about how we should focus our care. Is that okay? Now, getting news like that is hard, and we should expect an emotional reaction. And responding to that emotion can decrease the emotional intensity. So something that, I learned from social workers and we use all the time in palliative care is naming it. This must be really overwhelming. I can see that you're upset. I can imagine it's really, really hard to get news like this. I can only imagine, you mentioned your kids and thinking about them. I can imagine you're thinking about them now. This can be really hard. And our favorite in palliative care is the tell me more. I can see that this is really hard to hear. Tell me more about what you're feeling right now. We then want to map values, right? You can imagine Mr. F might say to me, so what do I do? I don't know if there's good treatment options moving forward. I can barely breathe. I don't know what to do. And it's very tempting to say, here's what we're going to do. 1, 2, 3, we're going to do these things. But I think particularly in serious illness communication, it's important to take a step backwards and to take a pause and to say it that way. I hear you. I want to talk about a plan. But before I can think of that plan, let's take a couple of minutes to talk about what's most important to you. So really adding in that pause that is intentionally focused on the patient and what matters to them. And then talk about them about their hopes and worries. I know we've talked a lot about where things are with the cancer. Having just gotten news like that, tell me what feels important going forward. Are there particular things that you're hoping for? And then as you think about the future, tell me, what worries do you have? Is there something in particular that worries you the most? So really focusing on those hopes and worries as an idea as a way to be able to create a plan for this patient. Now, they're going to share with you, honestly, often a lot. They're going to share with you things like, Mr. F might say, I'm really struggling to breathe and I worry I'm going to suffocate. There are times I just feel so anxious, like I'm going to suffocate. He might say, I'm so worried that my kids will see me suffer. I want to be at home. I want to be with them, but I want to make sure I'm comfortable so they don't see me suffering. So what you want to do is summarize and reflect back what you heard to let them know this is part of my decision making. I've heard what you had to say and I want to summarize it and bring it back. So Mr. F, what I hear you saying is that time at home with your family feels important and you worry about not being able to breathe and how your wife and your children are coping with all of this. I might also say something, depending on what he says. From what I hear, it sounds like having more time is the most important thing if it allows you to be with your kids for longer. I also hear you're worried about how they might handle seeing you get sicker. Does that sound right? Do I have that right? And I will say I always end with that question. Tell me if this is what I'm thinking based on what you just told me. Is that right? Is that the right evaluation of what you said? Then you want to propose a plan. So now that I've gotten some sense of what's important to you, this is what I think we should do moving forward. So, Mr. F, given what you've told me about your goal to have as much time as possible, and you mentioned your daughter is getting married in a few months and being there is really important. I know your oncologist talked about this new clinical trial and they're very hopeful that that will get you more time. If that trial is able to shrink the cancer and you feel okay, wonderful. But if it's not working and you're having more and more side effects and not good time with your family, we should stop it and focus on treating your symptoms. And with Mr. F, I might say, given that that trial is an option in the future, I think getting you in the hospital, maybe draining some of this fluid, managing these symptoms is important with the goal of getting you home. I hear you that you're worried you won't get home, but I think if what's most important to you is the chance at more time, then maybe we should go down this road. What do you think? Does that sound reasonable or no? Now, as I talked with Mr. F, He shared with me that he knows his cancer is incurable, and he also knows that he has a limited prognosis. He really remains very hopeful that the next trial could buy him more time. He is someone, he worked in healthcare and had a really strong sense of mission. And Mr. F actually just recently passed, but up until the time that he died, he really kept saying, I want to be able to go back to work. I want to be able to help others. And he really wanted that dyspnea managed. He was terrified that he would be at home and not able to breathe. And so the idea of going into the hospital to getting those symptoms managed was important to him. And so we had a conversation the way I've just shared with you. And that was where he settled on getting those symptoms managed and going into the hospital. Now, I just shared with you the REMAP framework with the citation, if you're interested in learning more. I want to share with you a different framework, which many of you may have heard of, the Serious Illness Conversation Guide, which I downloaded this right from the internet. So it's very easy to access for free if you're interested. But this is a similar framework that really does the same thing. It creates a way to talk about with patients about serious illness, and it gives you something to very much hang on to. This is what they refer to as the checklist for serious illness communication. So in this one, and you'll definitely see parallels between this and the REMAP framework, you want to start by setting up the conversation and say something along the lines of, Mr. F, I'd like to talk with you about what's ahead with your illness and do some thinking in advance about what's important to you, so I make sure we provide you with the care you want. Is this okay? You then want to assess the patient's understanding and preferences. So tell me what you understand, much like we did with the REMAP framework. What has Dr. So-and-so shared with you about your illness? And how much information do you want about what could lie ahead? It's then important to talk about prognosis, which we talk about prognosis and we often think you have 6 months to live, you have a year to live. We think of it in terms of time. And that certainly can be a type of prognostication, but we also can talk about uncertainties. This is something I talk about with patients all the time, that they've shifted into a new era where there's many uncertainties ahead. They may respond to this treatment, they may not. Things may get better, they may not. And they're living in that uncertainty. So we can talk about that, it can be difficult to think about what lies ahead. We can talk about prognosis in terms of function. I worry that over time, you may need more help from friends and family around you. And I want to think about a plan for that. And certainly we can talk about prognosis in terms of time. Again, once you've done that, it's then important to explore those hopes and fears and goals. What are your most important goals if your health situation worries? What gives you strength to think about as you think about the future? If you become sicker, how much are you willing to go through for the possibility of more time? And Mr. F was willing to go through a fair bit more for the possibility of more time. And then have you talked to your family? How much do they know about your priorities and wishes? And then once you've done all of that, you want to close the conversation. Mr. F, I've heard you say that being at home with your family is really important to you. Keeping in mind what we know about your illness, this is what I recommend we do. How does this plan seem to you? And always aligning with that patient. I'm always here and I'm going to work with you to do everything I can to help you during this time. You then clearly want to document your conversation and communicate it with any key clinicians. Now, I want to finish up by talking a little bit around the data around communication, because again, I'm sharing with you some basic communication skills, which I think they were important before coronavirus, they're important during coronavirus, they will be important after. And I also shared with you that we went through a time where many people said, you should never have these conversations on the phone. You should never have these conversations, anything other than face-to-face. That's a critical part of that. But we all had to shift, right? We all had to shift very quickly to suddenly be having these conversations virtually. Families often not at the bedside of patients in the hospital. In our outpatient palliative care clinic, patients not wanting to come in and sit in a waiting room and exposing themselves to the virus. So we've had to have more conversations on the phone and virtually. And so this article, just published in August of this year, or of last year, looked at end-of-life care in the time of COVID-19 and looked at how families perceived the end-of-life care their loved one received based on the type of communication they received. So to cut to the chase, this was one of the graphs from this paper. And what they looked at is what bereaved families thought about the end-of-life care that they received, and what they thought about the type of communication they received virtually. And not surprisingly, if they felt that they were communicated well with, so they were called frequently, they were able to do video visits, the team worked with them and had effective communication through virtual means, they often perceived a very good end-of-life care plan. And that's what those orange lines are. So the orange lines are the percent of families who perceived excellent end-of-life care for patients who had where they also said they have a very high score on the effectiveness of communication. The blue lines are the families that said, you know, the communication wasn't that great. They didn't call me that often. I didn't have good communication. You see a much lower percentage of them perceived that their loved ones had good end-of-life care. So there's a very strong correlation between communication and end-of-life care, and even virtually, excellent communication can cause patients and families to perceive very good end-of-life care. So I said that I would share with you some tools, and I want to give some here. So VitalTalk, which I mentioned, does some wonderful in-person and probably virtual now communication training around communication. And they also have a great toolkit around COVID-19 and communication in the setting of COVID-19. So I have the link right there. I shared with you the Ariadne Lab Serious Illness Conversation Guides. Here's the link to that as well. And then the Conversation Project, where I've borrowed some slides from, is a wonderful resource for encouraging patients to talk with their families about their wishes for end-of-life care. They have some great toolkits in general, and also specifically one around COVID-19. So in summary, it's important to have early and effective communication with our patients, to do it early and often. And while this may not be something you've a lot of experience with or had training in, there are some great tools out there that can really help us have these communications. And COVID has increased the urgency of these communications, of these conversations, and changed the way that we do them. Now there's a lot more remote than there ever was 2 years ago. And technology shouldn't be a barrier. In fact, it actually can be helpful in having us have effective communications with patients and families. So thank you, and I'm here if anyone needs me for questions.